Good morning, everybody. Is this on? Can you hear me okay? Great. Welcome, everybody, to our August Prenatal and Infant Care Network Luncheon. I'm Meg Disler. I'm the director of the St. Joe Community Health Foundation. Kind of tag teaming up here with me today is Laura Dwyer, who's over our community programs manager for the foundation. And we're delighted you guys are all here. This is a great topic for us to learn more about because it's so important in the community. Very quickly, the Prenatal and Infant Care Network, or this series of quarterly luncheons, are possible somewhat because of the support of the St. Joe Community Health Foundation, but also because we have a great network of partners who are the advisory committee. We can start by thanking Parkview Health for lunch, so thank you. And Erin Norton represents Parkview with all that, so thank you, Erin. At the bottom of it, we do have some of the other partners who are all very engaged in different areas of prenatal and infant care in the community, who have been volunteering in all different ways to help us put on these luncheons. So I actually ask if all of those in the room, would you just stand up for a moment so we can thank you for your work in helping us, just so we can see who you are. Thank you, Paige. Yes, yes. Thank you. The first thing we want to do quickly is we would like everybody to introduce themselves here in the room. And we have 15 minutes to do this whole room, so it's got to go kind of quickly. But we want to know the talent and resources in this room. So we do want to ask you to stand up, your name, your title, your agency. And if you have a new program or some new service that you want others in this room to know about so they can refer to you for something, if you could do it, but it's got to be quick, just because we need to get through everybody in 15 minutes. So it's a little bit of speed dating, but we think it's really valuable to hear the great resources we have in our community. So, Laura, do you want to start? Or with the mic?
I am Laura Dwyer, yes.
And we do ask you to stand up, and we are trying to capture you guys on film when you talk, your name. And so if we come back, we usually get a couple of emails or questions saying, I'm trying to reach such and such, and it helps us know who all is here so we get you connected for your referrals. So please,
so I will
don't be shy.
say, first of all, is this on? Can you hear it? Okay, good. I just want to tell you, I am so overjoyed to look out and see all these beautiful faces at this luncheon. As you know, we started with about 25 people, and now we're up to 85, 90, and we've actually had to cut off registrations in the past. So thank you. The work you do is so important in our community, and we're so thrilled to have you here, so thank you.
Hello. My name is Stacy. I'm with United Way 211 and Indiana 211 Open Beds.
Hello, I'm Janae. I'm also with United Way 211 in the Indiana 211 Open Beds.
Hi, I'm Megan, and I am also with United Way 211 and Open Beds.
Hello, I'm Alicia, and I'm with Healthier Moms and Babies.
Hi, I'm Rachel Blakeman. I'm the director of the Community Research Institute at Purdue University, Fort Wayne, and I'm here on behalf of the Lutheran Foundation, where I work as their project manager on the opioid crisis.
Hello, my name is Natalie Borjas. I'm with Catholic Charities. I'm the Hispanic Health Advocate. Currently, we provide interpreting and translation services for the Hispanic population. So if you have someone who speaks Spanish and is needing interpretation services, just let me know.
Hi, I'm Shanna with Journey Birth and Wellness, and we're new to Fort Wayne. We work with international and refugee women through pregnancy, labor support, and postpartum. And our goal is to train up ethnic childbirth educators and doulas so that they can support the women within their own communities to reduce cultural and language barriers during healthcare, and so that no woman has to labor alone.
Hi, I'm Danielle from Healthier Moms and Babies. I'm a nurse home visitor.
Hi, I'm Kayla Grazzini, and I am also with Healthier Moms and Babies.
Hi, I'm Madison, and I'm also with Healthier Moms and Babies.
There's a lot of us. Be prepared. My name is Chelsea Harris. I'm a case manager with Healthier Moms and Babies.
My name is Tiffany Jackson. I'm also a case manager with Healthier Moms and Babies.
I'm Ashley Nichter. I'm a case manager with Healthier Moms and Babies.
I'm Felia Lopez, and I'm also a case manager with Healthier Moms and Babies.
My name is Danielle Furge, and I'm a nurse at Healthier Moms and Babies.
My name is Maria, and I am a case manager and Healthier Moms and Babies, serving now in Noble County.
Hi, I am Tara, and I'm a nurse with Healthier Moms and Babies as well.
I'm Erin, and I am a nurse with Healthier Moms and Babies.
I am Shirley, and I am the nurse supervisor at Healthier Moms and Babies.
I'm Maria. I'm a nurse at Healthier Moms and Babies.
I'm Mary. I'm also a nurse with Healthier Moms and Babies.
I'm Becca. I'm not a nurse at Healthier Moms and Babies. But my name is Becca. I'm a nurse at Parkview, but I'm here doing some research for a paper for my BSN on substance abuse prevention in the community.
Hi, I'm Laura Ottenweller, and I am a board-certified swallowing specialist and a certified neonatal therapist in the NICU for Lutheran Health Network. And I work directly with infants and moms who are struggling to feed their babies and infants who have difficulty feeding because of withdrawal.
I'm Libby Martin. I'm the Director of Case Management for Lutheran Social Services.
I'm Emily Thiel. I'm the house manager at A Mother's Hope.
Stacia Roth, Executive Director of A Mother's Hope.
Brianne Beck. I'm with SCAN Healthy Families, and I'm a family assessment worker.
I'm Chantel Johnson. I am a community relations consultant with Anthem Indiana Medicaid, and we're one of the managed care entities for the state of Indiana for the Hoosier Healthwise Healthy Indiana Plan and Hoosier Care Connect. We offer a New Baby, New Life program for our moms that covers care coordination, educational resources, and also incentives.
I'm Linda Hathaway. I'm the Director of Education and Curriculum for McMillen Health. We have a new opioid program for middle school and high school students, as well as vaping programs for middle school and high school students. So if you need education, give us a call.
I'm Cami Rodenbeck, and I'm an educator at McMillen Health.
Marla Rust with the St. Joseph Community Health Foundation.
Amy Salek, also with the foundation.
Sharon Tubbs, also with the foundation.
Thank you to them also for all their help.
Marlene Krause with Bright Point Early Head Start. It's a home visiting program, ages 0 to 3, and also for pregnant women.
Hello, my name is Kajoy Barnes, and this is my coworker, Dr. Brandon Wood. We are from the Federal Agency of HRSA, Division of Healthy Start and Perinatal Services.
Hello, my name is Jackie Martinez, and I'm a program supervisor with Healthier Moms and Babies.
Hi, my name is Lisa Osterman with Community Solutions, and I'm working with Healthier Moms and Babies because Paige was worried she didn't have enough folks representing here.
My name is Paige Wilkins, the Executive Director of Healthier Moms and Babies. We, as many of you might know or may or not know, we received a federal grant last spring. And so these are our guests this week. They're here to help us with the implementation of it. And Lisa is our evaluator for the project. With that grant, I'm really excited to announce that we're launching a fatherhood program. And that fatherhood program, our coordinator for that is starting the 1st of September. So hopefully by our November meeting, we'll have more details to share and you'll be able to meet him.
I'm Ann Kale with Women's Care Center, and we offer free pregnancy testing, limited ultrasounds, parenting classes, and birth preparation classes.
Hi, I'm Marcia Worthington. I'm a nurse and a health educator, and I'm a community volunteer with Maternal Child Health.
Patty
Patty Leslie with Neighborhood Health Clinic.
Ty Nakabal, WIC Director. Hi, I'm Courtney. I'm with the WIC office under Neighborhood Health Clinic. We service pregnant women and children 0 through ages 5.
Hello, I'm Cheyenne. I'm with the YWCA, the Crisis and Domestic Violence Center.
Hello, I'm Leslie, and I'm from the Bowen Recovery Center.
My name's Corey McKenzie, and I'm one of the Parkview Community Health Workers with the Safety Pin Grant.
My name is Stephanie Gehring. I am a maternal child nurse navigator with Parkview.
My name is Destiny, and I'm a maternal child nurse navigator with Parkview.
Hi, I'm Carrie Eyrick. I'm Director of Hope and Harriet Recovery for Women and Their Children with the YWCA.
Hello, I'm Jennifer Pappert, the Clinical Counselor for Hope and Harriet Addiction Program through the YWCA.
Nancy Kripe with Tobacco Free Allen County.
Pat Turner, the Tobacco Education Coordinator with Tobacco Free Allen County.
Hi, my name's Amanda. I'm a nurse at Parkview North in the Family Birthing Center. And like Becca, I'm also a student and I'm doing a research project on infant and neonatal mortality.
I'm Lori Kramer. I'm an educator at McMillen Health.
I'm Elaine Wagner, and I'm an educator at McMillen Health.
I'm Holli Seabury with the Delta Dental Foundation, but here today with McMillen Health.
Nicole Fairchild, Executive Director at McMillen Health. We provide preventive health education to students from birth through aging adults. We also develop curriculum and media. And although I'm not with Healthier Moms and Babies, we are working on developing a preconception curriculum for them.
I'm Jen Story. I'm the Marketing Director at McMillen Health, and I help on said curriculum development and making it look right.
I'm just going to give her a plug. She actually designed this. So, yes. My name is Shannon Gleason, and I am the Assistant Director of Education and Curriculum at McMillen Health.
Hi, I'm Sarah Turner. I'm a family practice obstetric doctor at Lutheran Health Physicians, and I'm Director of Monarch Clinic.
Hi, I'm Erin Norton. I'm the Director of Community Outreach for Parkview's Women's and Children's Service Line.
Melissa Hall, maternal recovery specialist with Parkview Health. I help moms, both prenatal and postnatal, navigate if they have a substance use disorder.
Julie Reese, and I work with Healthier Moms and Babies, nurse home visitor. Hi, Brooke Traxler, Bowen Center.
Carolyn Warner-Greer at the Bowen Center.
Well, thank you. Every time I hear all the great resources in this room, I think we are a very fortunate community, and if we all can learn to work together and refer, we will save a lot more babies in this community. So thank you all for the great work you're doing. I echo what Laura said. We're delighted to see you here. We have a wonderful agenda today, and it just kept getting better and better as we were putting it together. We are going to start with a very special report by Dr. Holli Seabury that she worked on. She had approached the St. Joe Foundation a couple of years ago wanting to do more research to help understand what was going on with pregnant women suffering with opioids. So I am not going to do a long introduction of all of Dr. Seabury's accomplishments because we would never get to her talk. And so, but we're delighted that while she left her role at McMillen and is now the Executive Director President of Delta Dental, she is still so committed to this community. She's back to share some great news and the findings. So, Holli, thank you.
I'm going to pull it. Can you hear me? Okay, good. I'm normally loud enough without a mic, but I know this is feeding into the film. So I did, for 10 years, I was the CEO of McMillen Health. This was a report. You have the report that I worked on when I was with McMillen Health, and I'm here to present the finished report. And I am now with the Delta Dental Foundation. However, opioids and dental have a lot of crossover, so I'm still working with opioids. Thank you to the St. Joseph Health Foundation, Community Health Foundation, get the name right. So how do you know when a grantee moves to be a funder? This slide. Thank your funder. Always thank your funder. But in all seriousness, this was kind of going out on a limb for a foundation to fund this, and very appreciative of the funding for this study. And I'm going to start, before I talk about the background and the study, I'm going to start by giving you a few definitions, because I know a lot of you in this room do not work in recovery, and some of what is said and the acronyms are all kind of foreign to you. So I'm only going to give you 3 definitions. The other speakers may give you more. Opioid use disorder. This is, the old term was opioid addiction or opioid addict. We do not use that term anymore. The term that is used is opioid use disorder. You will hear it abbreviated to OUD a lot. Usually you'll hear it as OUD. There is also substance use disorder, which is abbreviated SUD. Medication-assisted treatment. So I'm going to talk a lot about this. This is typically called MAT. Some people refer to it as MAT. This is as part of recovery, taking a medication which does contain opioids with pregnant women, Subutex or methadone. And I'm going to, all the women in the study were on medication-assisted treatment, so you will hear me talk about MAT a lot today. And it is the standard of care for pregnant women with OUD as medication-assisted treatment. Neonatal abstinence syndrome, NAS, NAS, you will hear it referred to as that. These are the symptoms that are suffered by newborns who have been exposed to opioids in utero. So can be tremors, screaming, seizures, breathing problems, sleeping problems, feeding problems. So we will be talking about this. So the background of this study. We at McMillen do a lot of curriculum development, and we tend to have a focus on, in most of our outside curriculum development, on the Medicaid population, typically pregnant women and young children. And we were approached by Dr. Tony Giaquinta, who probably most of you in the room know his name. He's a pediatrician here in Fort Wayne. And last year, he was actually president of the Indiana Association of Pediatricians. And he asked to have a meeting with me, and we sat down, and he said, listen, somebody really needs to develop some good materials for women with opioid use disorder, talking about what to expect when their baby is born as far as withdrawal symptoms with NAS, developmental milestones, making sure the baby's on track. And I know you have at McMillen a history of working really well within health literacy and working with home visitors, and we'd really like you to do something. And I said, ooh, yeah, I don't really feel too comfortable doing that right now. There's not a large body of literature on working with this population, what they want from an educational intervention, what they think is missing. And I said, our work works closely with the end user who's going to receive our products. So until I get out and talk to some end users, women who've been through this, I don't really feel too comfortable doing this. And at that point, I think I'd had a conversation with Meg about this and saying, you know, and she said, well, what would you like to do? And I said, well, I'd like to do a study and sit down with a bunch of women and a bunch of professionals who work with women and talk to them. And she said, okay, yeah, why don't you write that up and send it in to us? And I did. And then Tony put me in touch with Dr. Sarah Turner, who will be presenting today. because she works with a lot of women who are pregnant or have new babies with OUD. And she was able to refer several of her patients to me to talk to. I ended up talking to 9 of her patients and 1 patient who wasn't her patient, which was extremely enlightening. The difference between a woman seeing a physician who is trained in substance abuse disorder and physicians who are not trained. All the women were either pregnant, 4 of the women were pregnant, the other 6 had given birth within the past year. 80% were on Medicaid, which actually tracks exactly with our national demographics. They were between 19 and 39. And then I talked to 17 professionals. A lot of you are here in this room. Your names are on the back of the report with a big thank you. And some of these professionals worked in recovery. Some did not. They were home visitors, they were early interventionists, but they were dealing with this population and feeling that they didn't have a lot of resources to do that. So, in talking to the women, 2 main themes emerged. A number of sub-themes emerged, which are in the report. But with time, I'm just going to talk about the 2 main themes. Pregnancy is a huge motivator for entering treatment or staying in treatment. 70% of the women were not in treatment before they became pregnant. So they entered treatment and a medication-assisted treatment as a result of the pregnancy being a huge motivator. 30% were already in treatment. Pregnancy was a huge motivator to stay in treatment. However, the guilt and stigma surrounding opioid use disorder and medication-assisted treatment during pregnancy was huge. Every single woman faced it. And I know the panel is that is the panel discussion about that. It was mitigated. Patients who saw Dr. Turner, it was mitigated by having her and her level of understanding. But sometimes it was more shocking to them than when they dealt with other medical providers who did not have that level of understanding because they had become used to it. And they were very shocked then when other providers did not have that level of understanding. So, the interviews were long, and we talked about 2 things. We talked about, tell me about your pregnancy or your birth, and how that went down, and what you wished you had known, and what you did know, and how you felt about that, and what your experiences were. And then we talked about education. What would you like as an education intervention? What would you have wanted to have moving forward? What would you like to see develop for other women in your situation? So they were pretty clear. They wanted education to be online. They wanted to be able to access it predominantly through their phone. They did not want another trifold brochure. I know those of us, we're all in public health here, and there's nothing we love more than a trifold brochure. But if you ever go into an office, how many people are all over those trifold brochures that you have on the rack there? I'm going to go with 0. And how many people are on their phone doing this in your waiting room? I'm going to go with everybody. That's how predominantly our phone is how we receive education, how we want to receive education. This is a stressed population. If you are pregnant with OUD, you are by definition a stressed population. So when we're experiencing stress, it's harder for us to assimilate information. The harder we make it for people to assimilate information by giving them lots of high-level written information, the less they're going to take in, and the more frustrated they're going to be. So they were pretty clear. They wanted short videos, and they didn't want them to be boring, which kind of goes without saying, but you probably do need to say it when it's a health intervention. They didn't mind if there was follow-up reading, but they wanted all the content to be in short video format. So potentially, it can look like this. One of the things when you look at developing education, and we're going to get into the content of what they wanted, is when you look at educational technology, which an app is educational technology, is you look at people will have intrinsic and extrinsic motivators. So an intrinsic motivator is, for instance, We have a video on medication-assisted treatment. We don't really. This is all, what it could look like. And I'm really motivated to learn about that. That's intrinsic motivation. I really want to watch that. However, we're putting in extrinsic motivation. You watch these 3 videos, you take a short assessment, you earn a badge. That's extrinsic motivation, and it really works in educational technology. It really works for people to earn things, for the screen to explode in fireworks and say, you did it, congratulations. That stuff works. So I would not ever advise creating an app that was just about opioid use disorder. I would see this as part of a prenatal and early childhood app that a component was talking about NAS, talking about substance use disorder. So women who needed that could go there. If they don't need that, they don't go there. And this is, okay, I really hope there's nobody from the state here, because I'm going to say something. The state does have an app, Live. It is a lot of written content. It is high-level written content. That's not really great for a population that is a Medicaid population, which is typically lower reading levels, higher stress levels. So what did women want when we talked about specific to education? What did they want? They wanted more education. So this did track with some of the research that's out there with families who have had a baby with NAS symptoms, that they really wanted more education. Now, this is not to say providers are not giving them education. What it is to say is we need to give it to them in a way that they can access over and over again, because when you are stressed, again, it's hard to retain education. They really wanted a chat room. This kind of surprised me. They felt isolated from the chat rooms that existed because they were on medication-assisted treatment, and if they mentioned that, they got flamed. And so they wanted a safe space where they could talk to other women who were going through the same thing they were. They wanted accurate information. One of the things that really concerned them was when they went online to get information, they thought a lot of it was probably wrong. They're right about that. They wanted more details on the withdrawal symptoms their baby could experience and what they could do to reduce those symptoms. This was one of the things they felt a lot of guilt about, knowing that their baby was most likely going to have withdrawal symptoms. They wanted information on developmental milestones, what should my baby be doing. They really wanted information on the Department of Child Services, how they work, what that process would look like if they had an open case. A lot of the women had prior experience with DCS. They wanted education specifically about how medication-assisted treatment could impact their pregnancy. And this was an unexpected finding. They wanted more information about nicotine usage during pregnancy. More than one woman said that she was surprised when she was told in the hospital that her baby was also having nicotine withdrawal. And the one mom said, I knew my baby would withdraw from opioids, but I would have quit smoking if I'd known he would also have to withdraw from nicotine. So, this is a quote. You probably can't read this, but this is a quote from a mom of a 7-week-old, and she just said, I feel like moms should be walked through step by step of what really is going to happen with the baby. Not in a way where it scares them, but just in a way where they know this is what's going to happen, so they're prepared for it. So, everything that we do at McMillen involving families is based on the Safe, Stable, Nurturing Families framework that's promoted by the CDC. There's more information about that in the report, or you can watch the entire hour of the talk I gave at one of these meetings on that. But basically, really promoting safety, stability, nurturing as a way to reduce stress in families. So then when I talked to the professionals, what they wanted, this is a nice quote from Erin Norton, who said, I've got community health workers out there. They could be talking about this, but I don't have anything to give them. So what professionals said they wanted was they wanted women to understand the importance of being honest with her medical provider about any opioid or substance use during pregnancy. They wanted women to have more information about the importance of the medical home so they could make sure that their baby was meeting developmental milestones. Because most women with OUD have a co-diagnosis of depression or anxiety, and in this study, every woman had that co-diagnosis, they really wanted a strong mental health component. Education on recovery and where to find treatment. And I want to make it clear, the education that's proposed in this is not recovery education. It is prenatal and early childhood education, but would be aimed at women who do have OUD. They wanted to be able to, so when we discussed the app, what they really liked was being able to log in, and this would be more for medical providers and home visitors, being able to log in and see what badges a woman had earned, what appointments she had kept, being able to suggest educational topics for parents to read. They really wanted to talk about the Department of Child Services also. That was both sides really wanted people to understand how that worked. They really wanted education in a format that could be used by home visiting organizations and other groups who work with mothers. And the family court really wanted education in there about how to prepare for a family court meeting. Overwhelmingly, what professionals said they wanted, if they did not work in recovery, was more education, more training, more resources that they could give mothers, and to have the curriculum laid out in a way where they could work through it from beginning to end of pregnancy through early childhood and have it designed to be a very clear path. There is obviously a ton more information in here. It was almost like writing a second dissertation for me. Not quite as bad. And if you have any questions, feel free to, we don't have time for questions right now, but feel free to get in touch with me after the meeting, or I suppose during the panel time.
Holly, you have a great way of making a very complicated project seem like I can understand it. So thank you very much. And to all the team for designing such a nice report. Thank you. Next, as I said, we have a lot of great speakers. We have Dr. Turner, who runs a very special clinic, and you've spoke to this group before, but it's been a little while. I wanted to make sure I was, yes, with the Monarch Clinic. I was afraid I had you the wrong order for a minute. And she's going to help us understand better what she can do and the resources there so you know when and how to refer or how to reach out to her expertise in the community. So, Dr. Turner?
I just opened it. Okay. All right. Hi, I'm Sarah Turner. I work with Lutheran Health Physicians, and I direct the Monarch Clinic. Monarch stands for Maternal Obstetrics, Newborn Care, Addiction Recovery, Comprehensive Health. A little bit about me. So I'm Canadian. You'll probably pick up on some stuff. It's not Minnesota, it's Canada. I say a lot. I did medical school in St. George's, and then I actually scrambled into residency up in Fort Wayne. I'd never been here before I got here. I actually wanted to do emergency medicine. Turns out I'm a family doctor. And then I kind of fell in love with obstetrics, so I went on and did a fellowship in maternal child health and addiction over at the University of New Mexico in Albuquerque. And then after that was done, we were looking where to go, and we had loved Fort Wayne so much, we came back. And another thing I did before I left was became an IBCLC. So it was in fellowship where I started working with women with history of opiate use disorder, substance use disorder, And I was terrified at the beginning because I was kind of like, how are they going to receive me? What's it going to be like? I have absolutely no experience whatsoever. And I absolutely fell in love with the population. They're people who are coming because they want to better themselves, better their lives, reunite their families, better their families, and it absolutely breaks my heart, the experiences that a lot of them have had. So my goal is to change that in the community. And so that's why I'm here talking to you today. I am a mom. I have 2 sons. This is Wesley, that is Simon. They're awesome. So SUD, Holly talked a little bit about this. It's defined as a disease, and I think this is one place where there is a lot of difference of opinion. A lot of people don't think it's a disease. They think it's a choice. It is not a choice. And kind of one of the best parts about this is because it's a disease, it's really up to the woman and her doctor to deal with this and not anyone else, her parents, her friends, her caseworkers, whatever. It's a disease. And so because we treat it like a disease, that's where the medication-assisted treatment comes in. It's a medicine for a medical problem. It's caused by a combination of behavioral, environmental, and biological factors, which a lot of diseases do. Genetics is actually 40 to 60% responsible in patients who are suffering from this. And so that goes along with stuff like diabetes and COPD and cancers. There's diabetes, COPD, and cancers that are very related to people's lifestyle and environment, but I'm pretty sure people picking up their metformin or their albuterol are not anywhere near as stigmatized as the women picking up her buprenorphine. So it's important that as a community we start looking at it like this, because it's the stigma that really prevents a lot of women from getting treatment. It cannot be cured. It's something that will be with them forever, but it is something that they can control. And it's something that does not define them. And so I'll talk a little bit more about that later in language. Opiate use disorder. Interestingly, we always hear that, like, marijuana is the gateway drug. And this actually was really interesting. People addicted to alcohol are 2 times more likely to turn to heroin. Marijuana 3 times, cocaine 15 times. Prescription opiate drugs 40 times. So really the gateway drug is Norco or Percocet, which, we're definitely tightening the regulations on this sort of stuff. It's not handed out as much as it may have been previously. But this is, in my experience, where so many of my patients started. It was a surgery, it was a back injury, a car accident, something where they were given a prescription and then the pain lasted, so they got another prescription, and then by that point they were addicted because it's about 2 months down the road. They got 2 months worth of prescriptions. Now they're going to ERs, dentists, another doctor, what have you. And then at some point, the pills are more expensive than heroin. So that's where a lot of people turn because it's just cheaper. 94% of people switch to heroin because it's cheaper. It's not that people are sitting down and saying, I think I'm going to shoot some heroin today. It's always usually starting with pills. And so the important thing about heroin and repeated heroin use is that it actually changes brain structure, brain chemistry, brain physiology. And so as much as people might think that it's a choice to do it the first time, which it may be the first time, at some point, they really are dependent. It's changed their brain chemistry. It changes how they're able to deal, how they're able to cope. It affects their decision-making abilities, their ability to regulate behavior. And really interestingly, one of the nurses that I worked with in my fellowship said, we come in and we're doing all this education on these women in, we had like an intermediate care nursery where a lot of our babies who were withdrawing were. And she said, you come in and the mom's 32 and we're talking to her the same way we talk to any 32-year-old. But if she started using drugs at 16 and she used drugs until she was like 28, she's 16 still. And we're not kind of addressing that. We're kind of assuming that they have all the same levels of coping, the levels of understanding, the levels of being able to reason the same way that a 32-year-old can, but that's just not always the case. So SUD and pregnancy, I talked a lot last year about this, so I didn't want to kind of repeat myself too much, but a quick brief overview. Reproductive women are at the highest risk, so pregnant women are a huge population of women who are suffering from SUD. And just some stats, in 2012, 5.9% of pregnant women used illicit drugs or used drugs illicitly, whether it was prescription drugs. 8.5% of them drank some alcohol, 15.9% smoked cigarettes. And a lot of them did more than one of those things. Most commonly, it was nicotine, then alcohol, then marijuana, and then you saw more of the opiates, meth, cocaine, some of the harder drugs. But the interesting thing is pregnancy is often a reason of recovery. At some point, they get that positive pregnancy test, and it's not about them anymore. It's about another person. And for a lot of women, especially ones who have lost children because of past decisions, this is their way to have a do-over and do it better and do it right. And so this is a huge motivator for a lot of women. Unfortunately, there are really high rates of relapse postpartum, up to about 35%. So it's so important that while they're in that recovery during the pregnancy, that we're setting up a framework and a network for them to fall back on in those first few months, and having a ton of like really close follow-up with multiple agencies, caseworkers, housing, what have you, so that we're there to catch them if they start to fall. SUD in pregnancy, it's associated with decreased prenatal care, poor nutrition, increased fetal and neonatal morbidity and mortality, increased complications of pregnancy, and then some other associations that we see are a lot of my patients, I'd say most of my patients, have some sort of a history of abuse, whether it's physical, verbal, sexual. Almost all of them have mental health issues. There's sometimes food insecurity, housing issues, poverty, lack of transportation. They have increased rates of HIV and HCV. I don't see a ton of HIV actually in Fort Wayne, but a lot of my patients have hepatitis C. And then they have a lot of chronic medical problems, diabetes, high blood pressure, other stuff like that. So it's a lot of stuff to deal with. And so when they come to me, I almost feel like the pregnancy and even the SUD is sort of the tip of the iceberg, because it's all the other stuff that's kind of stressing them out and making them come back to the substance use. This can lead to ectopic and tubal pregnancies, miscarriage, growth restriction, low birth weight, birth defects. Really, though, the only clear associations are with alcohol and benzodiazepines. There's some studies that are showing other links, but nothing really solid and clear. Placental detachment, yep. Benzodiazepines, sorry. Xanax, Klonopin, trying to remember, Ativan. Yep, anti-anxiety meds. So placental detachment, or also known as abruption. Or what? Yeah, there's tons of anxiety meds that can be safe in pregnancy, but benzodiazepines, again, we see an association. It's just, I don't know, it's still up for debate in a lot of areas. So we do still use them sometimes. Most of the associations are earlier, so when I do see them, it's usually later, and even then it's not huge risk. I've seen people use them, but it's people more who are abusing them through it that we're trying to hold back on. Preterm labor and delivery, stillbirth, increased infant mortality and SIDS. And then we see in kids later abnormal cognitive development, behavioral disorders, decreased IQ. And I feel almost like that's the one that hits home for a lot of women. So unfortunately, like a lot of the other stuff, they just feel like it's uncommon, it's rare, it's not going to happen to me. But when you worry about their kid not coping as well or having the smarts, that's sort of the one where I feel like a lot of people get it. All right, so screening of patients. This is, how do we screen patients? Ideally, in a perfect world, every single person coming into prenatal care gets screened at that first appointment. It's not often the reality, unfortunately. Urine drug screens is what a lot of people do. It underestimates use. There was a study that showed that 88% of women who were meconium positive, only of 88% of women who were meconium positive, only 52% of them actually were urine drug screen positive. Self-reporting, it underestimates use, of course. People are terrified about telling you something like this. They don't want to say it because they don't know what's going to happen. They don't want to be punished. So 48% of women with a positive drug screen still denied use on admission. And I've had patients like this. You know, you were positive for cocaine. Your baby was positive for cocaine. The cord was positive for cocaine. Yeah, I never used cocaine. So you see it, and I mean, I get it at a point, but selective screening based on our educated guesses. You look like someone who would use drugs, so I'm going to ask you, but you over here with the pearls and the cardigan, probably not. So there was some study I read where it said something like 40% of women who are using substances in pregnancy have no risk factors. So we're missing a lot of people if we just kind of selectively screen. So interestingly, July 1st of this year, House Bill 1007 went into play. It's an Indiana bill, and it requires anyone who's practicing obstetrics to screen with a verbal, validated, evidence-based screening tool. And I'm pretty sure, I mean, I don't know about private people, but I know that Parkview, Lutheran, NHC, and then the Family Medicine Center, we've all agreed on the same one. If it's positive, we either treat or we refer them to treatment. And then we cannot report the results of screens or tests to law enforcement or DCS without a court order or patient permission. This is one that I hear a lot of uproar and outrage about, because people are like, what do you mean we can't report them? You know, what if we're worried about stuff? I mean, you can still report if you're concerned about neglect and abuse. But more importantly, the patient who shows up in my office at 6 weeks has a positive drug screen for, say, heroin, who gets herself onto Subutex and remains in recovery for the entire pregnancy, gets out of her housing situation, you know, does everything she's supposed to be doing. She's not going to lose her children just because of that one positive drug screen. There has to be other factors in play. And that's why I'm thrilled about that part of it, because I feel like it protects the people who are trying to do the right thing. So the 5 Ps is the screening tool that we are using. So this stands for parents. Did any of your parents have problems with alcohol or drugs? Any of your friends or peers have problems? Does your partner have problems? Before you were pregnant, in your past, did you have any problems? And in the past month, i.e. in your pregnancy, have you ever used alcohol or drugs? So, I mean, everyone's going to have sort of a different way of addressing a positive screen. A negative screen obviously is a negative screen, but you get a score from 1 to 5. And I'm actually working on the Lutheran side of things of coming up with sort of an algorithm, so it makes it so they don't have to decide what to do. Some of it, you know, obviously if it's your parents or your peers, it's counseling. If it's your partner, it's more heavy counseling. Are there issues with abuse? Do you feel safe, or do you feel pressured to use? If it was in your past, you know, again, counseling, we would probably do a urine drug screen, and then figuring out if it's an issue now. And then obviously in the pregnancy, this is what we're all here for. So, medication-assisted treatment, it's a medical disease, so we treat it with medicine. There are 2 different medicines that we're generally using in pregnancy, methadone and buprenorphine, also known as Subutex. Buprenorphine plus naloxone is the Suboxone component. We generally don't use that in pregnancy because naloxone hasn't got the studies behind it to show that it's safe. It probably is, but this has shown improved prenatal care, improved nutrition, increased birth weights, reduced infections, reduced crime. Both methadone and Subutex have similar maternal and delivery outcomes. Both have risks of neonatal abstinence syndrome. Methadone has a little higher risk, and when they do withdraw, it has longer hospital stays, more medications needed. And then detoxification from everything. You need to get clean. You just need to stop. You need to get off of everything. A lot of people think that's the answer, and I've had patients who've been told that's the answer. The official stance from ACOG is that is not the answer, because we have a risk of miscarriage, of stillbirth, of preterm labor, and as well, it's really, the relapse rate's over 90%. So you ask someone to stop something that they're actively using, they're probably potentially still, you know, around it. You know, they don't have the resources. This is their coping mechanism, and pregnancy is so stressful, especially now that they're worried that their baby's going to be taken away. So it's definitely not the time to try and make a massive life change like this. ACOG's official thing says that withdrawal from opiate use during pregnancy is associated with poor neonatal outcomes, including early preterm birth or fetal demise, higher relapse rates, and so it shows that generally we just keep them on opiates, but a more controlled way of doing that. So methadone, it's a long-acting opiate medication. The half-life is pretty long, so babies tend to have longer withdrawal from that. It has to be dispensed by a treatment program for substance use disorder. You might hear of physicians doing it for pain, which we can do, but for the substance use disorder, it has to be dispensed. So that means for a lot of patients, at least at the very beginning, daily dosing. They have to show up every single day. They have to meet with counselors and do all this stuff, which is fantastic for people who, especially people who have polysubstance abuse. It's a daily accountability. So it kind of keeps them in check. They can't just go home and use it if they want to use it, not if they don't. And it kind of gives them, like, again, a good, strong framework to fall back on. And a lot, you know, meeting with your counselor on a regular thing. My patients love that. They feel like it's such a huge place of support for them. What is difficult about methadone? For a lot of patients who live really remotely, live an hour, 2 hours away. Yep. Oh, yeah. Sorry.
Back to the detoxification.
Yes. No, nicotine isn't strong enough to, like, cause miscarriage. We do recommend detox. I'm talking more about, like, opiates specifically. We do recommend detoxification from cocaine, meth, PCP, all the other stuff, but it's just opiates specifically where we get the risk of stillbirth, miscarriage, and preterm labor. Yeah. Yeah, I mean, it's not, nicotine withdrawal is definitely not enough to put a baby into NAS, but it can just heighten the symptoms. And so if a baby's kind of scoring, say, moderate, if they were to smoke, it might just bump them up enough that they're now scoring and upset and, you know, inconsolable enough that they will meet treatment. And it's just because it's a stimulant or depressant, so the withdrawal symptoms are very similar. We actually also say the same thing from SSRIs, which are the most commonly used antidepressants. There is sort of a behavioral syndrome that can go along with some of the NAS, and a good majority of my patients are also on SSRIs for their depression during the pregnancy. So it's hard though, and I counsel them, you know, especially if it's a person in new recovery. You know, you've just given up heroin, and two of the hardest things in the world to give up are opiates and nicotine. And so obviously I want them to stop smoking, but my just feel is kind of, you know, if you can quit smoking, that would be great. If we can cut down on smoking, that would be great. But if going down on it's gonna even remotely put your recovery of the opiates in jeopardy, keep smoking, it's fine. You know? Oh no, they should definitely. If they can do it, they should. But I kind of tell them you know, especially early in recovery, sometimes the smoking is what helps them kind of have something, you know, which I know sounds terrible, but sometimes they just need, it's hard to give up two incredibly hard habits. So please give up the one and we'll deal with the other one later. And a lot of my patients will at least cut down. So, you know, we try and get them down as much as we can, but it's that last step, it's those last few cigarettes that are the hardest. I smoked for 14 years. Those are the hardest ones, the last couple. So again, it's not gonna make them have enough withdrawal that they need treatment, but it's enough to kind of bump them up. And it is, I don't know, it's hard. It is hard for a lot of moms to hear that. I try to warn them, but there's so much information that I'm giving them. You know, studies say that they retain 40% of what we tell them. So I tell them things over and over. And I try, but it's hard. It's hard to give them all that. Harm reduction. Exactly. I know. It is. And they don't give themselves enough credit. This is a population who will blame themselves for anything. They could give up heroin, they could quit smoking. If they're on an antidepressant, oh, I read somewhere that could do it. That's why my baby's withdrawing. I'm the worst mother in the world. You know, I'm gonna lose my baby. They're so hard on themselves. And it's so hard to give them any sort of praise. And it's funny because you give them, like I had a patient I discharged this morning and she's done amazing. And I was telling her, you've done such a great job. And she was all worried about DCS. And I'm like, well, you've done a great job. You've shown it in my office. You've shown it in your counseling. You know, if you need help, I'm here. And she just like started bawling. She's like, no one's ever told me they're proud of me before. I'm like, that's heartbreaking. You know, that's what they do in their recovery is so hard. And they don't ever give themselves enough credit for it. There's always something they're doing wrong. There's a reason somewhere that they're the worst mom, you know, but I mean, can you blame them? That's kind of what society's telling them all the time, you know, so yeah, methadone, it's hard for a lot of patients. I know patients who travel an hour and a half to get to the methadone clinic, and they do it because the recovery is so important to them. The other doses are really based on cravings and withdrawal symptoms. So in pregnancy, generally their dose needs to go up. And interestingly, their baby's withdrawal is not about dose. That's a big misconception, and it's so hard to get the patients to realize this. It's all about their stability. So if you have a mom who's on 40 milligrams and she's having like withdrawal symptoms and cravings and she's trying her best not to go up on the dose, her baby will actually withdraw before someone who's on like 180 milligrams and feels great. And I've seen it. I had a patient on 189 milligrams and her baby didn't even remotely withdraw. So That's a big, and same with Subutex. A lot of people think it's the dose. It's not the dose at all. It's about stability. So for someone who's at baseline at 120 milligrams, they might go up to 140, 150. Some patients don't go up much at all. Some go up a lot. Everybody's different. Everyone's physiology is different. It doesn't require any withdrawal for induction, which is important to a lot of patients. There's some people who hate the withdrawal. And so the fact that they can take some methadone as they're sort of coming down without getting sick, that's the selling point for them. Buprenorphine is newer. It's not been around as long, but most experts in the field feel like it's, yes. Okay, okay. They feel like I'm gonna skip over this then, because it's good. Subutex is great. All right, barriers to treatment. Location is a big one. They might be remote from clinics. There might be not a lot of Subutex providers. Cost, some people are paying out of pocket or they don't have insurance. They may not know about the resources available, and then a lot of them fear in getting in trouble. There was a state that actually stated that it's child abuse if you use any drugs in pregnancy. So to admit that you've been using them is huge. From DCS, going to jail. And then there's the stigma from work, family, neighbors, friends. I was looking online last night for just little memes about stigma, and it was heartbreaking. And there was a couple that I wanted to put on, and my husband was like, "No, it's too much. Please don't put that," because there was stuff that said like, a lot of them are anti-Narcan. Narcan is free. Why is my insulin this much money? And there was one that said, "Let those junkies rot. Narcan should not be free." I mean, and they go on there and they read this, and they feel like that's what society thinks, and so that's why they feel like they're worth nothing and that they are garbage, because people just want them to die. Government drug dealing. I have been referred to as a drug peddler by multiple people, which is awesome. I know I'm not. I'm okay with it. So the fact that people think that I'm making money or profiting off them being on Subutex, I don't make any more money than if they're coming in for a cold. I do it because I care about them. And then there's people who say that you're trading one drug for another. Well, you do the same thing in diabetes with insulin. It's a disease. We're trying to fill the gap and fix the receptors. These ones, Narcan's free. Why isn't chemo free? Why is EpiPens expensive for people when Narcan's free? And then I saw this one. I don't tend to love Jim Carrey all that much, except that he is Canadian. But he had this post where you had this. And the question isn't, why is the Narcan free? Why is the insulin $750? His quote was, "Other people who are struggling are not your enemy." It's embarrassing that it needs to be explained, and it is. It's embarrassing that we feel like we have to attack other people who are struggling. Special considerations. I'm going to kind of fly through some of this. We talked about other things, food insecurity, housing. Language is huge for people, and I correct staff, patients all the time. We need to have more compassion for people and hear what we're saying to them and hear how we're saying it to them. Patients don't see themselves as sick. They see themselves as they're bad people. My drug screen was dirty. They associate it with filth. I'm an addict. Well, you're not an addict. That's something you suffer from, but that does not define who you are. They feel a lot of shame and embarrassment. They feel ostracized, especially as Holli was saying, from like the mom groups. And so the important thing is using patient-centered language. Focus on them, not the disease, as we don't want to call people diabetics or people autistics. We call them a person suffering from autism, a person suffering from diabetes. This is a person suffering from substance use disorder, because otherwise it reinforces negative stereotypes. I'm an addict. I can't escape from this. This is who I am. This is what I am. I can't ever be anything else. And in studies, clinicians are more likely to favor punitive measures when we use stigmatizing languages. And so it really can become self-fulfilling. Just some things to not say and things to say instead. And this is really I have to talk to people all the time. You're not an addict. You're not a junkie. You are a person with substance use disorder. You have substance use disorder. You're in recovery. You're not clean. You're in recovery. And then my biggest pet peeve, babies are not born addicted. That just makes parents feel terrible. They are dependent. Addiction implies a behavior. They are not addicted. I hate hearing it so much, and I see it all the time in notes. I hear it all the time from patients. I hear it all the time from staff. Nonverbal cues. These patients are very overly sensitive. If you say something that isn't even remotely offensive, sometimes they take offense anyway because they hear something a little different or they heard something before. It reminds them of something. So it's really important to show respect to them without language. Make eye contact. When I'm sitting and talking to them in the hospital, I sit next to them instead of like standing over them and talking down. The tone of voice is really important. Body language is really important. Don't cross your arms while you're talking to them. And then being aware that a lot of them aren't comfortable with touch, especially when there's history of abuse. So, and it's a lot of trying to read their verbal cues. If someone looks like they need a hug, I'll ask them, can I hug you? Do you need a hug? But not just doing anything else. And then that's it. Yes. Sorry, no questions.
Thank you. Thank you. I keep learning, and we have another wonderful speaker. Dr. Carolyn Greer is newer to Northeast Indiana, and at Bowen Center, they have a lot of great new programming opportunities for you to be able to refer patients. So, Dr. Greer, give a little bit of your background, because you've sat on a couple of sides of this issue, so you can bring it to us. Thank you.
Hi, everybody. My name is Carolyn Warner-Greer. I'm a physician at the Bowen Center right now. I went to med school here at IU and did my internship and residency and fellowship in obstetrics and gynecology at Methodist, which is now IU. I then went back about 9 years ago and did a fellowship in addiction medicine. And I haven't delivered a baby. It's about 10 years now. So it will be 10 years in a month. So, and then instead work primarily in the field of addiction psychiatry right now. I've been at the Bowen Center for about a year and a half after working. I'm from Rushville, Indiana, which is like on 26 towards Purdue and Kokomo. So I'm new to this area in town, but my husband is from Fort Wayne, and he went to Notre Dame, so we're pretty close to the things he likes too. So, in 2019, there's some things that we look about with the women that are unique. One of them is that we know about 500,000 pregnancies are complicated by psychiatric illness. We know that most of these women will report that they haven't had any care. We know that suicide is the leading indirect cause of death for pregnant women, meaning something that's not related to its pregnancy alone, but merely associated with the state of being pregnant. And we also know that about 4% of women meet the criteria for a substance use disorder, not including tobacco. If you put tobacco in there, it would go up to about 11%. As Sarah shared already, we know that neonatal abstinence syndrome or neonatal opioid withdrawal syndrome affects about 7 out of 1,000 births. She talked about this also, that the most common person to be abused as a female is a pregnant female. We know that women with mental illness, whether they're pregnant or not, are much more likely to use tobacco. The adult tobacco, which is now unfortunately increasing because of the use of electronic nicotine delivery systems, but up, say, 2017 numbers, the adult rate of tobacco use in the United States was less than 12%, whereas women with mental illness, it approaches 50 to 70%. We also know here in our area that why we are very concerned about opioids, that the last 3 quarters in Fort Wayne, we had more methamphetamine poisonings than we did opioid poisonings. So we need to think about all substances that are misused and can create problems for the health of an individual, let alone a pregnant woman. We know that marijuana use has decreased in some subpopulations, but in lower socioeconomic groups, it has increased. And we know that probably more than half of women will continue to use marijuana during pregnancy. This is a conversation I have frequently, that we have definite, marijuana is a little bit more difficult to study because it's so pervasive, but we have definite associations with early development in the child as well as the adolescent brain with the use of cannabis. Those cannabinoid receptors are very important in the development of the fetal brain. And again, like last year, the first time the incidence of smoking at childbearing age increased to 14% from 11%. So, young women are the ones who are most likely to smoke. We know when we've done different surveys through the state that about 60% of women report drinking sometime in pregnancy, and about 23% report binge drinking during pregnancy, which would mean more than 4 drinks at one time. When we talk about mental health, we're going to include substance use disorders in that also. We're also going to include mood disorders, such things as depression, anxiety, and bipolar disorder. trauma is part of mental health, whether it be childhood or just the ongoing stressors. And then again, serious chronic mental illness, such as schizophrenia, thought disorders, and things on the autism spectrum. So, and again, we talk more about opioids. It's more not just opioids. We're talking about stimulants, not just methamphetamine, but prescribed stimulants, tobacco, which is the most common, alcohol, benzodiazepines, again, which would be Xanax, Ativan, Valium, Klonopin, different medicines like that, and then marijuana. Just because someone uses substance does not mean they meet the criteria for substance use disorder. There is a difference. Not everybody who gets a DUI is an alcoholic and has an alcohol use disorder, and not everybody who has an alcohol use disorder is going to have any legal complications. Again, Sarah talked about this again. What addiction is different. This is the sort of the aftermath of substance use, and not everybody meets those criteria. So how do we approach? We agree with screening, and everybody, there's nothing in medicine where everyone, Sarah knows this because she belongs to different colleges than I do, and we don't agree on anything, but we definitely agree on screening everybody in pregnancy. And Indiana is unique that we have a law now that reports this, even though it's been best practices for a decade or longer. The 4 Ps, or I guess the 5 Ps is sort of an offshoot of that. We use the CRAFT, which is more for younger people that has to do more with peers and getting in trouble and things like that. We recommend screening for mood disorders in pregnancy, and these are things that can be done by a layperson who is trained maybe by someone to understand how to introduce these questions. The spontaneous brief intervention referral to treatment in pregnancy is not found to be helpful, which we do that more like in a population of an emergency department. The biggest reason is because of that stigma of substance use in pregnancy, that just the brief flyby kind of thing usually is met with a negative response. Sarah can tell you there's an art to screening. If we're throwing this in with our nurse who's going to ask about how many times you've been pregnant, how many miscarriages, do you have diabetes, blah, 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 and then says, oh, by the way, I'm going to throw in these 5 Ps, it is very easy to say no. And all of us in here have taken care of someone who had a negative screen at the beginning of their pregnancy. I would challenge to say that this screening needs to be done in the preconceptual age, so every well woman's checkup, because maybe there's a little bit less on the table there, but this recommendation by the American Academy of Pediatrics to screen for substance use at every visit after the age of 12. Definitely preconceptually, we should be talking to people about substance use in an evidence-based manner. The tool of motivational interviewing, of talking to people and putting it out there that it's okay to say yes. You don't use drugs. How about some women struggle with anxiety and stress? Some people have been exposed during our opioid crisis to these substances, and they may find themselves, it's very hard to quit. Pregnancy is a great time to address this right now. I have help for you. That's more likely to elicit a positive answer. I gave a TED Talk back in April here for TEDx Fort Wayne, and one of the things I talked about was a mom that I saw who hadn't seen her baby in a year because she'd used fentanyl her entire pregnancy. And I asked her, did anyone, and she did not see Dr. Turner, obviously, I said, did anyone ever ask you, did you struggle with substances, anything like that? And she goes, no. She goes, they didn't. The nurse did that real quick ACOG prenatal form. That was the end of it. I wanted to tell someone I wanted to help. I was so scared because I was pregnant that they were going to take my other children away. So screening can address, we're not here. Again, there's a law here that says that we don't have to report substance use alone, because substance use does not mean abuse of a child or neglect. Treatment, again, there's multiple ways of taking care of people. It's best when you're counseling someone that you have access to all these treatments as well as knowledge of how they apply. Frequency of visits, talking to a doctor, no offense to nurses because there's a lot of out here, but patients will, in every chronic illness, will say advice from a physician is worth much more than the handouts. I cringe when I listen to my nurse. I'm going to go to my outpatient office here after I get done. And one of our screening questions at the Bowen Center is, do you smoke cigarettes? Do you want to stop smoke cigarettes? And she will say it. If they said yes or no, I don't even know if she would hear, because it's just one of the things we do. But when I talk to someone about their tobacco use and the impact of using motivational interviewing, not using a shaming, stigmatizing language, I know that I'm going to get more response. So I have to take the time to do it. It's much easier to ask my nurse to do it, but I have to be the one who does it. So a take home today is that if you identify someone with a mental health concern, they should be evaluated by a physician or a psychiatrist or a nurse practitioner, or a physician assistant, somebody who can see if medication treatment is helpful. If they say, I don't want to take medicines, I just let them be evaluated anyway, okay? We struggle with this, and even in our own center, because we're so big and we have so many employees that will look and say, oh, someone has a diagnosis of generalized anxiety disorder, and they've never seen a provider. And we have lots of providers who can see them. And we may say, I think you're doing well with cognitive behavioral therapy, you're doing well with lifestyle modification, you have a good app called Calm that's helping you. You might not need any medicines, but we need to give them the opportunity to discuss that. So when I see someone for depression, I have doctors, we have differential diagnoses where we say we're going to rule this out, and then it's this. The number one thing that I rule out with mood disorders is a substance use disorder. Most community mental health centers have problems with siloing. We have substance use, and then we have mental health. They're all the same thing. They're all behavioral health, if you want to use a different word to make it easier to roll off the tongue. But I can't tell you how many people I see once now they've had an arrest, they've had a child born, and they see me and they say, I've been using, Xanax for 10 years. And I look and I'm like, oh, you've been getting care for your anxiety. No one once ever asked, and if they did ask, did they follow up with objective testing? It's a struggle because there's so much stigma about, I want you to pee in this cup. What do you think about me? That kind of thing. So it's our job to make sure that there is no stigma and to say, like with many things I look at, I'm going to draw some blood to look and make sure your thyroid's not out of whack, and that's why you're anxious. I'm going to look at your blood count. I'm going to look at your testosterone for men to look and see if that's causing your depression. We have to be able to use this objective tool and remove the stigma so we can find out what's actually going on. So, some things about pregnant women who have substance use disorders. As we've seen, they're 5 times more likely to have co-occurring mental illness. They're more likely to have physical or sexual assault in their history, and almost 60% of them meet the criteria for post-traumatic stress disorder. Being in active addiction is traumatic. Okay, being arrested is traumatic. Being involved with the Department of Child Services is traumatic. Being in a courtroom is traumatic, and those things, I know that Judge Pratt has told me that he had brought in a study earlier this year to look at trauma-sensitive care. Like Sarah said, some people don't like to be hugged. When you have a male bailiff and they're yelling at somebody, that is reintroducing trauma. This population is so affected by PTSD. So we approach these things in a public health manner. We're going to emphasize on treatment, not being punitive. We're going to emphasize on harm reduction. Substance use does not mean that you're abusing and neglecting your children. Absence of substance use does not mean that you're not abusing or neglecting your children. And address the root cause instead of focusing on drug test, which many people do in pregnancy. I just need to have a negative meconium, negative cord blood, and negative urine when I go in to have my baby, instead of looking at all the root cause and all the things that are keeping them in that cycle. So, we participate in a lot of harm reduction at the Bowen Center. Medicines are not harm reduction, those are actually treatment. But the Allen County has a syringe services program which produces a lot of harm reduction. And I'd have to talk to Susie to find out that the percentage of entrance into treatment, but nationally, syringe services programs are a really good way of getting people into treatment. Naloxone distribution is very important. Anyone who has an opioid in their home, even if they're in treatment for an opioid use disorder, not because they're likely to suffer from an opioid overdose, but because our patients are more likely to recognize someone who is suffering from an opioid. They're not going to be afraid to intervene, and they would be much more comfortable administering first aid. There was a great study done of giving people in opioid treatment programs, giving all the participants naloxone rescue kits, and the number that were used. The perfect example is I'm walking up my steps to my apartment at night after my second shift work. I see someone slumped over a steering wheel. People who've never struggled with substance use I don't want to get involved. Oh, he must be sleeping. People who've used heroin or fentanyl, they know what that means, and they're more likely to jump in and help. So that's who we need to arm with these tools. So we have challenges with looking at medicine. Sarah, it's difficult to talk about what does Xanax do, what does benzodiazepines do, what does being treated with an opioid for neonatal or for maternal substance use, what does that do for the growing child, because it's multifactorial. Genetics play into this. the stability of the home, the parenting style. There's so many things that play into this that it's very difficult to really know what's going to play in there. We have lots of pregnancy registries where people can report. I used prenatal, I use this medicine at this point of my pregnancy, and this was for congenital birth defects. When I was, and I don't know how old Sarah is, but I'm older, I think, when there was a time where paroxetine or Paxil was like the go-to medicine for premenstrual dysphoric disorder or PMS, and it was detailed to us in women's health. Give everyone Paxil, it's the best. Well, all SRIs work fine, but they got an indication. Well, then, fast forward 6 years later, we're seeing an association with cardiac defects with women treated with paroxetine. So again, it's we learn by experience, but it's really difficult to say this caused this. So the FDA now labels medicines differently. They're not going to go back and relabel everything, but everything new medicine, they're going to stop with the letters, because really in pregnancy, everything's a C. Okay, we just don't know. There's some things that we feel comfortable giving it a B. There's some things we feel comfortable giving a D or an X. But honestly, they're going to start relabeling things that we're going to look at. You just have to look. You can't do Google medicine and just look on your app, infant child risk. Oh, it's a C. No, you can't take that. You better not risk it, because treatment of people without medicines is risky too. Untreated depression is very risky in pregnancy. Untreated anxiety can be risky. Definitely, we've learned, over years that untreated substance use disorders are also risky. So we get together as a team and we all work together to decide what is the best way to go. We pull in our psychiatrists and our obstetricians and our pediatricians, and we figure out what's best for this individual patient based on what we know about these medicines. We all agree, which is unusual, that we all get together and agree about anything, but we agree for the reasons that Dr. Turner mentioned. That the risk of return to use with detoxification or withdrawal management of opioids approaches 90%. The best way to avoid having a positive drug test is to not take the drug test, which means that you just don't come to prenatal care, which we can all agree is not associated with good outcomes. Tobacco and alcohol, we don't really have a good consensus on treatment. We agree that you should not smoke or drink during pregnancy, and fetal alcohol spectrum disorder can involve, we tell people it can involve as much as one drink can cause fetal alcohol spectrum disorder. We have to hinge that with saying it would be best going forward if you don't drink alcohol. Stimulants and marijuana, we mostly use cognitive behavioral therapy, but again, we have to actually use the cognitive behavioral therapy, and we have to show people. There is so much medical technology now where they don't have to, which my CEO would kill me, they don't have to come and see us. They can do things. We have apps. We have internet-guided studies to help with people who are struggling with some of these substances. So again, we use a lot of CBT. Contingency management is difficult. That's simply giving increasing rewards for a very objective, reachable goal, such as a negative urine test. Again, with contingency management, we had a meeting about this morning at the Bowen Recovery Center, and we said, well, where do we get the rewards? And that is a challenge. But of all these approaches, the most effective is contingency management. The effect goes away when you stop, but in the moment, it's pretty helpful. So. What I get a lot of phone calls about, and I am not from Dr. Turner, but everybody else, is the management of women during labor and then again postpartum as far as pain goes when they're treated with an opioid, partial agonist or agonist for the treatment of their substance use disorder. A goal is that, and then when you're working with these women, you say, well, why do you need Percocet when you're on 140 milligrams of methadone? Well, the methadone, the buprenorphine, the buprenorphine with naloxone, those are all baseline medications. Women who have an opioid use disorder have a higher opioid debt to begin with. An anesthesiologist will tell you this. When they're using fentanyl to put them to sleep, they're like, I'm using more and more and more to get them to quit moving. That's an objective finding, not subjective. They're not reporting, I need more. Their muscles are reporting, I'm not relaxed. So best practices, again, for postpartum pain management have changed. We've done tons of studies that show that sending someone home, when I had my youngest is 13, and when I went home, I got a prescription for 120 Percocets with 3 refills. That's ridiculous. We know that no one needs that, and the most likely thing that's going to happen is that they're either going to sit in the medicine cabinet, and then my adolescents at the time are going to use them, or I'm going to go back to them in 2 or 3 years. We know that the average amount of medicines used after a cesarean section is around 20 pills, and we don't want to put a barrier to anyone, but we also don't want to have those medicines. It's important that we talk to our women about disposal. You're done, you're 3 days post-op, you're done with those medicines, let's dispose of those appropriately so they're not at a risk for someone else. It is important with vaginal deliveries that you don't have to necessarily have a big old bottle of Vicodin to go home. It's not your treat for having a baby. The baby's the treat. So, this postpartum period is really risky. Suicide and postpartum depression, postpartum psychosis are huge. I start my patients who are pregnant, I start them again on an SSRI at about 36 weeks because the incidence is so high. I don't want it to be forgotten. I want them to have it there, and I get a lot of agreements on this that was a helpful thing to do. We need to increase our services, not drop them off. Oh, you had the baby. Okay, now you're out of this program, out of this program, out of this program. This is what you guys all do. You put them in different programs that are going to be helpful. Breastfeeding in hospitals, and I haven't seen this as much in the Lutheran and Parkview system as I did in the community system, community hospitals where I came from. But it only takes one nurse to tell someone you can't breastfeed because you're taking methadone, or you can't breastfeed, you're going to get the baby high, or breastfeeding is what's helping the baby not withdraw because they're getting so much methadone from your breast milk. Neither one of those are true. The reason we encourage breastfeeding with the children who struggle with neonatal opioid withdrawal syndrome is because that skin-to-skin contact, nurturing, quiet, that's what's helpful to reduce the likelihood of having to use medicine and reduce the likelihood of prolonged hospital stay. So, just briefly what the Bowen Center does. We talk about the hub and spoke model where we have a hub of where there's intense services, intake services, and then we let people run out to the spokes. And this West Virginia obviously was just killed by the opioid epidemic. They modeled this where we have some hubs of places where there's lots of services available, and then we farm people out. Not a great word, but we send people out. And then if someone's in one of those spoke arrays and they are worsening, or they're using again, or they're having struggles, we ship them back to the hub and people can move freely back and forth. And not only do the patients move back and forth, but communication moves back and forth. So everybody's talking to each other. The hub for us is an opioid treatment program. The Bowen Recovery Center is the name of one. We have another one in Fort Wayne called Center for Behavioral Health. We have one in Marion. There's going to be one, I don't even quote me. We had 11 until we opened the Bowen Recovery Center, and 4 others. We went up to 15. This is the governor's initiative, is to reduce that rate so you don't drive an hour to go to treatment. His goal is less than 30 minutes. There's 5 more opening in 2019. There's licenses for another 5. The caveat is these new opioid treatment programs are not the for-profit model ran by an out-of-state entity, but instead ran by community mental health centers. The credentialing of the people who are providing services here eclipses anything we've ever seen before in OTPs. I was on a conference call yesterday with medical directors of all the OTPs, and you can tell who, well, that's because we're all addiction psychiatrists, but you can tell who's running the new ones and then who's, running the ones that are a cash basis for profit. It doesn't mean that they don't do good work, because they have for a very, very long time. It's just that we're going to up the game a little bit, and hopefully what we're going to see is that they'll start credentialing their counselors, nurses, and physicians a little bit more so we can all provide. Because again, we can't shut down the existing ones to open the new ones. We'll have the same problem. So daily attendance, like Dr. Turner said, daily attendance means daily accountability. When I'm going to see people today who I treat in the outpatient for many things, but the ones I treat for opioid use disorder, I won't see them again for a week. That's the fastest I will, because I don't go to any office more than once a week. A lot can happen in that week, okay? Lots can happen in that week. But when we see them at the Bowen Recovery Center, we see them every day. So when everything is fine on Wednesday and the world's crashed down on Thursday, we're going to know about it. Because most of us, when we're in our misery, we don't pick up the phone and say, hey, I need help. Most of us just live in the misery until there's a consequence. And then our outpatient offices are our spokes. We have a larger menu out there. We have therapists, counselors, skills coaches, and then if people have a regression, we don't fire them and send them to, you did bad, you have to go to the BRC, which happened a little bit at the beginning. More so that we're going to escalate your services. We think you need more help, and we want to make sure that you can get it in a more intense. So no matter where the opioid treatment programs are located, there's always access. We have, for the Bowen Center, have mobile clinics, and I don't even know how many counties now, 22. So mobile services, so they don't even have to have a building there. They can be able to tap into our services, and then those services talk to our bricks and mortar buildings to make sure. So I see people all the time from Wells, Adams, Jay County, Tipton County. I'm in Wabash a little bit, so I see a lot of people more from the south where we have mobile counties. Howard County, which is where I live, is wonderful. My daughter's a senior in college, and her friends are graduating, and I'm sending them all to the Bowen Center to get jobs. So I'm going to ask HR because I want the money. I've sent a lot of people here and not put in for it. So we have a thing called an echo clinic, which is just people, experts around the table getting on and talking about cases, doing didactic lectures. There's one for adolescent medicine. There's one for pediatrics. There's one for hepatitis. There's definitely one for opioid use disorders. There's one for pregnant women. And anyone can tap onto that and listen and see what's going on. They're on Wednesdays from 12 to 1:30. If you just go to the IU psychiatry department, you'll be able to see. And then we can start collaborating with local physicians. Doctors will tell you that we have, I don't call the doctor, I have my nurse call their nurse. And a lot gets lost in there. Just in the last couple weeks, I let Kirk Carlson know, our CEO, and I'm like, I need a work cell, one that I can give to people and say, just call me. Okay, don't try to call and get a hold of me and that kind of thing. Because when I need to know something right away about the treatment for hepatitis C, I want to pick up the phone and call our local GI guy and find out for sure. There's plenty of us. We're not overburdening each other, but our patients get taken care of better that way. And then I don't see someone, they're like, oh yeah, well, so-and-so did this. So we have skills coaches, which they're called all different things in different systems, but they're bachelor level providers who work with patients. I always say I talk to you across the desk, and then they go out and do the real work. But we have these in every single county, and these are the ones who are getting things done for us. My wise person told me that if all you have is a hammer, everything looks like a nail. So if you have a program that offers one thing for every single person, then crazy, but every single person will need that one thing. It's good to have a menu. The other thing is we don't want anyone to say, well, I don't live in Fort Wayne, so I can't access those services. Again, one of the things skills coaches do is provide transportation. We all communicate. It doesn't matter where you are. We want to make sure you can get help. So just some final thoughts. I said this before, the most common way of avoiding detection of substance use disorders, just don't get care. Most women, again, when surveyed, and we saw this in Holli's report, most women are convinced that if I do a drug test on you, I'm going to report it to CPS. All my patients are convinced that I'm talking to the law. And that as soon as they have a positive drug test, I am just dialing up our local sheriff's department. That just doesn't happen. But this population, they need reassurance over and over and over again. We know that when someone is struggling, telling them what harm is going to happen is not helpful as much as information about what could happen. Instead of talking to people about the consequences, if you keep smoking pot, CPS is going to take your kid. How about saying, instead of educating around the negative impacts on the developing fetal brain, the money they're spending on marijuana, how they're risking getting violated on their probation, all these other things, and let them come up with it. That's just motivational interviewing. So, and the goal is wellness, not just passing that test at the end. FACOG, which is the American College of Obstetrics and Gynecology, which I'm a fellow of, as well as the American Society of Addiction Medicine, which I'm also a fellow of, we both oppose mandatory reporting laws. I think it was, and Sarah can correct me, I think it was, wasn't it Kentucky or Tennessee that they passed two laws? One was you have to report it's child abuse, and then the other one was there was like a safe harbor law, so they sort of contradicted each other. But we, our colleges are against mandatory reporting, so. And the next steps for the Bowen Center are integrative health care. We've put in an application for a federally qualified health center, but regardless, we're going to have in the next 5 years integrative health care in every single one of our sites, which the blue zones are places in the United States where people live longer and report a higher degree of happiness. And the common denominators are is that they move naturally, they have a right outlook, right tribe, and eat wisely, which just translates into exercise, diet, sleep, community, and altruism having something important to do. So it's really exciting to be involved in this, especially because I'm married to an internist, and I'd like to move here and not drive an hour and 45 minutes each way every day to work. So if the Bowen can hook him up, then we can drag our kids kicking and screaming to Fort Wayne. So if you ever have any questions, anything you need to talk to me about, I have some cards up here. I really do answer my phone. The Bowen Recovery Center answers their phone 24/7. So if someone is struggling and you just don't know what to do, that's a good place for rapid access for all sorts of problems. So thanks for letting me share today.
Wow, my head is spinning with great information. We are now going to have a short panel where we'll have more questions and answers, and they can go a little freeform. So if you all would like to come up, Dr. Turner, Dr. Holli Seabury, and I think, and actually, we'd like you to come back up. It's kind of a casual, and we have a couple of questions for them, but if you have questions, Paige, you can even start with your question because you patiently waited.
You need me to talk now? Carolyn, you actually touched upon my question that I was going to ask Dr. Turner. It's probably one of my biggest pet peeves in the entire world. It drives me crazy. I want to know if it's getting better. I do not understand why we are giving women narcotics after they have a baby, especially for a regular vaginal birth. I mean, that's nuts. And they're going home with a prescription of 90 pills with a refill on it, and it was a normal vaginal birth. I could understand maybe a C-section, but that doesn't even seem. And if you are working with women who have a substance abuse disorder, I'm going to start saying that, Dr. Turner. But if you're working with women that have a substance abuse disorder and you're sending them home with that, you're setting them up for failure. And you're even, not only that, but there are women who stalk Facebook and know when people have babies and go start raiding their medicine cabinets when a baby comes home from the hospital because they know that women are going home with a prescription of Vicodin. So is that still, with this whole process of doctors getting more restrictive about what they're prescribing, is this getting better?
I mean, I don't send anybody home after a regular vaginal delivery. The only exception would be if someone had like a 3rd or 4th degree tear. Yeah. But even then, they're getting a couple. Yeah, it's not. Yeah. They're not getting. I've never given out 30 with a refill. I mean, I never give refills for one, but
I know when I had my kids.
But I can't speak for everyone. I think, as far as I know, with WHA, because they're the only group that I'm working closely with, I don't think they do. The family medicine residents are definitely not, because they don't really have much of a license yet. So, but I think it's definitely gotten better. In terms of after a C-section, a lot of my patients with SUD have had C-sections, and that one's a little tricky because a lot of them actually have a lower pain tolerance. So in the hospital, we're having to use, and especially if they're on Subutex, because Subutex blocks the receptor. So for them, a 10 of Percocet's like a 5 of Percocet, which we don't even, like we use 10s for people without. So that one's a little tricky because a lot of them do need to go home on a little more, but I tell them, I'm like, this is it, you ration it. Do what you want with it, unless there's like some crazy reason you're not getting more. And they really do really well. I try to maximize and schedule Tylenol and ibuprofen, and then instead of using actual Percocet and Norco, I use just pure oxycodone because you actually end up using less opiates if you use high-dose Tylenol. People don't give Tylenol enough credit for how well it works. So, yeah.
So when did this standard kind of start changing? Because with my kids, now granted they're older, 10 and 8, but that was one of the very first things that they wanted to give me, and I had normal births. They wanted to give me Vicodin, and I did go home with a prescription of Vicodin that sat in my cabinet. I took most of it. But
I'm not sure how much it's actually, I don't know. Again, I can't speak for when I delivered my son in 2014, Vicodin was on my list of things I could have for pain, and I had a pretty normal delivery. But I know, again, my experience is only with the Lutheran system. We have a new computer system, and so we have all new order sets, and the standard order set no longer includes Norco for vaginal deliveries. No. So you can order it, but you have to be asked. So it's not like it's just available for them to get if they want to get it, which is good.
Does anybody know what
People don't give it enough credit. And I think the problem is like people don't realize it's not, you can't just take like an ibuprofen for, you know, pain that's caused from like a lot of inflammation. So like C-sections and vaginal deliveries, there's lots of baseline inflammation. One pill is not going to do anything. You have to take a few doses before it gets to a level that actually decreases inflammation. And so that's where, you know, well, I tried a dose of Tylenol, didn't do anything. Okay, well, like take, you know, take this much every 8 hours, and after a day, you should actually be feeling pretty good. I had a patient who, she was an SUD, but she had a C-section, a scheduled C-section, and she used 2 Percocets. That was it. That was all she used the whole stay, because we had scheduled. And I was like, she was a resident, so I was like, can I test my new protocol on you? She was like, sure. And I mean, she did really well. And so that's kind of like, if she can do well and she's a normal person who had a normal delivery, I mean, we do overprescribe it. And people, I think a lot of people, especially breastfeeding moms, don't overuse it because it makes you tired. But there is something to be said for the women, especially since so many women start with pills. Pills is the beginning. It's not without harm, for sure. Yeah. I think it's, I mean, as far as I'm concerned, I'm pretty sure people have tightened it up a lot. In fact, I feel like a lot of the Women's Health Advantage doctors have come to me and been like, well, I have this lady on methadone and I did her section, like, what do I do? Like, I feel like a lot of them tend to want to undertreat, you know, and she's on the, like she said, you know, she's on methadone, but the methadone is the maintenance. And I think a lot of people don't realize that. So I see it with people who are pregnant on methadone or Subutex who get their teeth pulled. They have their teeth pulled and they get nothing, which, I mean, they should get one or two. I mean, it's painful. And they can't take ibuprofen while they're pregnant. So, so yeah, I think the tendency in the community is to go away almost maybe a little. Yeah, so I think we're moving in the right direction.
Okay, go ahead.
Difference of opinion. I think the important thing is it's a law. Like, we can't, unless we truly have concerns about abuse or neglect. If a mom, I mean, okay, we live in a state where marijuana is still illegal, but in places where it's legal, I mean, really, a mom puts her kids down to bed, her kids are safe, they're sleeping, and she has a couple glasses of wine, or she smokes a joint. I mean, really, if it's like, it's not like she's smoking pot while she's driving her kids to school. I feel like to make a blanket statement that if they admit to using ever, that we have to report them, I mean, we know that's wrong. I don't know. Well, and so, I mean, I guess the law basically says unless we're concerned about something else, if it's just that you've screened a mom and she admitted to use, or she has a positive drug screen, if there are no other documented concerns, we can't, which I think is, it's good. I think it's good, you know, especially, you know, and this is to no knock of DCS, but there aren't a lot of standardizations necessarily, and it's really kind of who you get sometimes. And some of them have openly admitted they think that methadone or Subutex in pregnancy is child abuse. So it's so hard to counsel patients because they all ask me what's going to happen, and my answer is I have no idea. The best thing you can do is focus on your recovery during the pregnancy, and every time you come here, if they ever do ask for your records and you give them to them, look at all what you've done. Look at all the counseling appointments that you've done. Look at all, going to the methadone clinic that you've done. That's the best you can do, because there's really no other way to counsel them.
We have a question back there. I'm going to ask you to stand up and talk very loudly, because I don't think we can run back and forth.
Here's a way to talk about patients who are treated with medicines that no one's on anything they're being treated with. So that's one thing to start with there. When we take care of pregnant women, that's a decision between her and her doctor. Again, that would be assault if we force someone to take a medicine. And patients have the right to know how much medicine we're giving them when they're in treatment for an opioid use disorder and an opioid treatment program when we're treating them with methadone. So there are... The idea that someone who experienced opioid withdrawal is going to instantly, go into preterm labor is pretty conceptual and not really borne out in any way, shape, or form. Women withdraw all the time from opioids, okay? We incarcerate them. We put them in lay treatment programs where they treat them with abstinence as best. It happens all the time, and it's not 1 = 1 kind of thing. The reason that we don't want people to stop treatment for opioid use disorder when they find they're pregnant is because the risk of return to use is so high. There's no reason for it. But if you have someone who says, I'm gonna reduce my dose. Oh, yeah. Mm-hmm. Sure. Again, that's in the continuum of taking care of people with opioid use disorders is what we're going to do with your medicines. And to know that it's not a black and white. You don't say, okay, well, I'm going to stop, and then tomorrow, oh, guess that didn't go well. When we taper people off of medicines, if a week later they're like, all I can think about is calling my dope dealer, and I'm having withdrawal symptoms, I can't take care of my kid, and I don't think I'm ready yet, titrate them back up again. So I would encourage, though, talk to your providers. There's no absolute yes or no for anything. So yeah. So either way. It's tricky. Again, methadone works so well because it has a very long half-life, but it also takes a long time to taper it off too, safely and appropriately. But again, if you've been in active addiction for 10 years, you can spend a year, and it's okay.
So this came up again and again in interviews, is the cost of treatment if you were on Medicaid during your pregnancy. That Medicaid typically ends at 6 weeks postpartum. If women did not have private coverage, the cost of methadone was brought up again and again. And so it was often, I need to get off of this. I can't afford it. And the one mom makes the comment, I can either pay for diapers or methadone. I need to make a decision. And so that is a problem. I mean, it's a big problem, and it falls into relapse, is the cost of treatment once Medicaid is lapsed and you do not have private insurance. So I think as we look at education for people who work with mothers who are not in the recovery field, what those options are for women in that situation, that needs to be better publicized probably. And
yeah, at the Bowen Recovery Center, 97 or 98% of our patients have insurance covering their treatment. So the idea that methadone is too expensive to continue is not a case. Again, we have presumptive eligibility. We have an expansion of Medicaid. We have a grant that we use to help people with their co-pays if they can't pay it. So again, the reflectiveness of cost, making that you can't get treatment for something, is less and less, and at the Bowen Recovery Center is non-existent. The cost is not a reason people quit coming. So. Yeah. Yeah. Pregnancy-related Medicaid was very much before we had a Medicaid expansion and we had HIP. So most people who qualify for pregnancy-related Medicaid will also qualify for the Medicaid expansion, which as of 2017 covers opioid treatment program services. So.
I am mindful of the time, and it's a great, and there might be other questions, but I would like to ask each of you guys to give you time to give your last words of advice, keeping in mind that most of the people in this room are out in the field directly working with people, not in structured clinics in-house. So any advice that you would have your last words?
Give people permission to say, yes, I'm struggling. Go ahead and even assume. I know that a lot of people, this could happen. Give them an anecdote. One time I was taking care of this lady, and she was so scared to tell anyone about it, but no one's going to get offended. If they really have no problems at all with alcohol, tobacco, prescription drugs, they're not going to get offended, okay? Especially in the way you deliver it. But give people permission to say, yes, I'm struggling and I need help.
I'm like, I wanted to say, like, be kind, but I think all the people in this room are the people who are being kind. It's everybody else that needs to learn more about stuff. So, I would just continue to educate all the people who aren't interested in this or aren't educated in this or aren't working with people in this population that, this is the future of medicine. So most people in medicine are going to have to do it. Most people in nursing and hospitals and clinics and mental health. This is the future, and this is what we have to deal with. So we have to kind of blaze the trail and be really passionate about it, which I think, again, everyone here is. So thank you for that.
I think from my perspective and talking to people who are not in the recovery field, but who work with women, really over and over and over again, it was like, I don't know what to say. I don't know where to refer them. I don't know what to tell them. I don't know what's right and what's not right. And to hear, and what I heard over and over again was, when I hear that women are on a medication-assisted treatment during pregnancy, that seems wrong. It seems like they shouldn't be doing that. So just that education of, yes, that is the protocol, why it's the protocol, that I think that needs to happen, because the women I talked to got a lot of, they knew what was right, but they got a lot of misinformation from other people who didn't understand that and didn't have that type of training. And I think overwhelmingly people want to know what's right and what they should be saying. And so we need to help people who don't work in the recovery field but do work with women get that training.
Thank you very much. Let's give them a big round of applause. You guys were fabulous. So one thing, I'm shameless. Please fill out your evaluations because we really do want to hear from you. And our next luncheon is November 21st, and we are going to be talking about maternal health in that 4th trimester, and we will have an expert on insurance and what coverage they can get after they deliver. So thank you all for coming. It's always great to see you, and thank you all. You are fabulous.